and I'd like to welcome everyone to the final session of the conference, which is going to be a panel discussion about specialized care for aging people living with HIV. I'll be your moderator for the session, and I'm going to introduce our fabulous panelists this morning. Just to give an overview, they're each going to have 5 minutes to introduce their topic, and we're going to leave most of the time for the session to have discussion for your questions and comments and build on the lively discussion from our prior session. So I'm just going to briefly introduce our panelists. Our first speaker will be Dr. Angela Kondo. She's an assistant professor in the Department of Geriatrics and Palliative Medicine at Mount Sinai in New York City. She provides primary geriatric care to older adults and also does geriatric consults at Mount Sinai Peter Kruger Clinic. Our second speaker has, one of our speakers will be Dr. Amanda Willig, who is an associate professor in the Division of Infectious Diseases at the University of Alabama, Birmingham. And she is also a registered dietitian and holds a secondary appointment in the Department of Nutrition Sciences. She has an outpatient dietitian practice at the UAB 1917 clinic and does research on nutrition and physical activity in older adults living with HIV. Dr. Nancy Sheehan is a clinical professor in the Faculty of Pharmacy at the University of Montreal. She practices at the Chronic Viral Illness Service at McGill University and does research on drug-drug interactions and the pharmacokinetic and pharmacodynamic determinants of virologic response. Mr. Jules Levin, who is the founder and executive director of the National AIDS Treatment Advocacy Project based in New York City. If you're not familiar, which you all are, provide conference coverage, education, and advocacy focused on HIV, hepatitis C, hepatitis B, and metabolic issues related to HIV and aging. I also want to introduce Dr. Ferrucci and Dr. Ansis, who have maybe need no further introduction, who have already been introduced earlier in this conference, and thank them for joining our panel as well. With that, I'm going to turn it over to Dr. Kondo, our first speaker, who's going to introduce general geriatric care principles.
Thank you so much for inviting me here today. I'm really excited to talk about our HIV geriatric program at Mount Sinai. And so I'll spend a few minutes talking about our multidisciplinary clinic structure that's dedicated to the care of older adults with HIV. And to do that and really highlight the geriatric approach, I'd like to share the short story of Mr. D, who is really just a made-up conglomerate of patients that we've seen. But Mr. D is a 78-year-old man. He's been coming to Mount Sinai's Peter Kruger Clinic for over a decade, and so has established great relationships with his primary care doctor and other staff members. He's really one of the strongest men I've ever met, not by any physical measure, but by his resilience and grit. He came to the United States as a young man from another country. He was the victim of 2 serious accidents that left him functionally impaired. But despite that, he worked as a home health aide. He really cherishes his independence, but acknowledges that he needs more assistance at home. And so he was referred to our program for a comprehensive geriatric assessment. So with that short blurb about Mr. D, I think it's important to note that I did not start by telling you his list of comorbidities, but rather, who Mr. D really is as a person and what really matters most to him. And that's crucial to the geriatric approach and really how we try to address patient care in our program. So patients like Mr. D are referred to our comprehensive program of integrated care for older adults with HIV. Our program is lucky to be supported by grants from the Keith Haring Foundation and now also the Health Resources and Services Administration, or HRSA. Our team includes myself as the geriatrician, a nurse who has been working at the HIV clinic for many, many years, a pharmacist, a social worker from the HIV clinic, and also soon to be community health worker who will be adding to our team. And we take referrals from Mount Sinai's HIV primary care clinics that's under the Institute for Advanced Medicine, and that includes 5 different clinic sites throughout Manhattan. Now, our team is embedded physically 1 day a week at one of those sites, which is the Peter Kruger Clinic. And we've structured our referrals to really coincide with the 5 M's of geriatrics, meaning patients are referred for one or more of the following reasons: multi-complexity, review of medications or polypharmacy, mobility concerns, or what matters most, and really starting discussions around advanced care planning. We do provide a guideline on referrals for patients 50 years of age and older, but really happy to help in any way that we can for patients, let's say, that are maybe even a little bit younger who are experiencing geriatric issues. Our new patient appointments are an hour in length, and follow-up appointments are 30 minutes. So patients are really welcomed prior to their appointments and escorted to our program if needed by our community health worker. Our nurse will perform an initial triage, including vital signs, a welcome to the clinic, a depression screen, and a falls screening questionnaire. Our pharmacist does meet with each and every patient, reviews their medication list, answers any medication-related questions, and performs an interaction checker, as well as identifying if any medications are on the American Geriatric Beers criteria, which are potentially inappropriate medications for older adults. Then I, as a geriatrician, will meet with the patient. And again, we really talk about what matters most, what comorbidities are most bothersome to the patient, for instance, what's affecting his or her functional status or quality of life. I'll complete different geriatric assessment tools as appropriate based upon the reason for the referral. We certainly talk about memory and mood, complete different cognitive screening tools such as the MOCA or PHQ-9. We do talk about patient social situation and supports in the community. If there are any social work needs that arise, I'll connect with our social worker, who then identifies whether the patient has a primary social worker at their primary care clinic. And the reason for this is really to ensure that the patient's care is coordinated rather than fragmented, and that those longer-term relationships are maintained. Now, based upon our visit, we create a problem list and come up with an action plan, and we agree on a time to meet again to reassess how things are going. I'll send a summary of our visit to the patient's primary care provider to ensure everyone's on the same page. Now, our community health worker will function in helping patients really navigate our recommendations outside of the clinic and keep us informed of any barriers and the progress in our recommendations until we meet again. So that's really a brief summary of our clinic structure and flow. I hope that was a little helpful to just tell you what we're doing here in New York City and at Mount Sinai, and I'm happy to take any questions later on. Thank you.
Thank you for that, Dr. Kondo. And now I'm going to turn it over to Dr. Ansis, who's going to talk about neurological assessments for the aging people with HIV.
Thank you. It's really a pleasure to be here. And that was a wonderful introduction by Dr. Kondo. And I think we'll continue on with Mr. D and his presentation and taking further steps. So as a neurologist, I'm often referred individuals, and especially older, but also even younger individuals who may have some kinds of memory issues or may also have other neurological issues. In particular, neuropathy issues are very prevalent also in persons living with HIV. In regards to the kind of neurological assessment, I'm really starting to talk to that individual and trying to, as you heard from in Mr. D's situation, what is the baseline of that individual, and are there changes from that baseline compared to the past? Now, that's sometimes difficult in some patients, and why I say that is if they may have memory issues, they may either kind of say that they're not that important, or they may not even appreciate those kinds of deficits that they have. So I often encourage, if it is possible, to have a collateral source. So somebody who really knows that individual, has been with them, can kind of give a good history and talk about, in this case, Mr. D, how he is doing and if there are significant changes. So I'll give you an example in particular, and maybe in this case of Mr. D. If Mr. D is doing his taxes, and I ask Mr. D, have you ever done your taxes? And he says, I don't do my taxes. And then the next question is, have you ever done them? And if he's never done them, that's one issue. But if he was, say, in the background of also being a healthcare person, but also was a, say, certified public accountant or something else like that, that is a significant change that's going on in the individual. So I'm trying to look at how they performed in the past and how they are now, and trying to really get an understanding of what's going on with this individual. And that's why that collateral source is going to be so important for really helping out and filling in some of those gaps that may be occurring. When we're evaluating the individual who's in the office, it's very, very tough to do a full, complete examination and do all of the different kinds of tests in a prescribed period of time. So what we're left with is, as you heard from Dr. Kondo, is we often are doing some kinds of screening tests. And one of the tests that you heard about was the MoCA, or the Montreal Cognitive Assessment. It is a pretty good, and there are other ones in HIV dementia scales. They're all pretty similar. And if you look at the different ones and what they're asking for, they're giving us a general flavor. They are not specific to this disease, or they're not even specific to other diseases. So we may be having somebody who may have Alzheimer's disease. They're not specific. All they're telling us is that there is some kind of cognitive impairment. And I know we have Dr. Moore and a number of others on here as well who do. And what we then will do, if we do see some cognitive impairment on these kind of screening examinations, is to refer them for full or more complete neuropsychological testing. And I do that because I really want to get that, again, that baseline, and kind of understand those areas where people are having deficits. And then we can actually try to think of ways to help correct some of those different areas. We'll also do a complete neurological examination that includes looking at their cranial nerves, their strength, their reflexes, their sensation, and their coordination, as well as their walking. That can easily be done in a short period of time. And then I will be ordering, if need be, some labs. So there are reversible causes of dementia. And the question is, what are those kinds of tests? So we'll get some simple metabolic labs and look for some kinds of changes, but we'll also look for other infectious disease labs. And when the individual is sitting in front of me, I'm kind of thinking about their age. I'm thinking about what their complaints are, thinking about some of the medications, and we've heard even in previous talks, and we have leaders in the field in some of these areas, are what kinds of antiretrovirals they've been on and what antiretrovirals they're on now. You also heard from Dr. Kondo, we're thinking about comorbidities that this individual may be having as well, and kind of using all of that. Plus, I'm also looking at a couple other lived factors that these individuals have had, their lived experiences. And incorporating that, I'm asking them, where do they live and what is their environment that is present, and their access to healthcare. A little trick that we did, and you also heard it from Dr. Peterson yesterday, that we're looking at, is we're even looking at kind of the zip codes and kind of figuring out where they're from, what access is actually going to give me a little bit of an idea of how many kinds of exposures or what part of their lived experience is. Now, if this individual has some more cognitive issues and I'm worried about some kinds of things that are happening, and this individual, I may be doing a lumbar puncture, which would allow us to look for if there's any escape. And then we often may be doing imaging testing, but we don't typically order those kinds of tests, not at least at the initial go-round. So it's kind of developing that rapport, bringing back that individual, and working in a team environment, which really helps us kind of identify that individual. So that's kind of the neurological. I know we're having a lot of questions that are coming out on some of this. I'll hand it off to our next colleague, and then we can handle a number of those questions that are starting to pop up in the chat.
Yes, great. Thank you so much, Dr. Ansis, for those perspectives. And we are going to go right into our next panelist, who is Dr. Willig, who's going to be talking about nutrition and dietary issues for aging people with HIV.
Thank you so much. I'm very excited to be able to speak with you a little bit today about some of the things that we are able to do at the 1917 HIV Treatment Clinic in Birmingham, Alabama. So our clinic is very fortunate in that we do have multiple registered dietitians on site who can actually screen and see patients throughout their clinic visit. We also partner with the social workers who are in our clinic to treat some of the different conditions and answer some of the questions for patients as well. Whenever we look at a lot of our patients who are aging at our clinic, we realize that there are really two situations that come up a lot with aging. And the first of these is the issue of overnutrition and the second, undernutrition. So whenever we're thinking about these, we first target the issue of food security, then nutrition security, right? So every single person each year who comes into our clinic for a visit will get screened for food insecurity. So this is sort of the vital crutch of the overall system. So again, our registered dietitians and social workers at the clinic will perform this. If you don't have staff who can readily do that full assessment at your clinic, you can administer the 2-item food security questionnaire, which will help you identify those individuals who are food insecure. Now, at least in the United States, sometimes participating in food assistance programs can actually be associated with worse health outcomes due to some of the food that is actually available. We are very fortunate, again, that we received approval to utilize funds through the 340B drug pricing program in the United States to provide and operate a food assistance program. So we partner with the community group, Birmingham AIDS Outreach, to provide food assistance and minor small equipment assistance for patients identified as food insecure that are tailored to their appropriate needs. So if we identify someone as food insecure, we give them the option to connect with Birmingham AIDS Outreach. We fund the equipment and food provisions for monthly food boxes, medical meal delivery, or nutritional supplements, depending on what's appropriate. Also items such as water filters. So does your patient have refrigeration access in their home? Is there clean water source available through tap water in their house, or are they obtaining their water through the water hose in their neighbor's backyard? So we have to do a lot of those types of assessments. We also look at the fact of, is the individual functionally and cognitively capable of preparing their own meals? So a lot of those initial questions will go into the assessments if someone is determined to be food insecure, of identifying how to best help them with this 340B program funded food assistance effort. So then we get into the general screening of nutrition itself, where we said that we look at nutrition security. So is someone undernourished or overnourished? And if so, how can we treat that, right? So in the general population, whenever someone hits around age 65, something is happening physiologically. We haven't quite figured out what it is yet, but what we do know is that around that age, even when you control for the amount of lean mass or muscle mass a person has, they're burning fewer calories. They just are than what they were burning in prior years. Okay, what we don't know is if this happens sooner in someone who's aging with HIV. We also know that that process of losing a little bit of lean mass in general starts when someone's 35. So if someone is age 55 and they're eating the exact same amount of calories as when they were 45, but they're not doing any exercise to maintain their muscle mass, they're eating too many calories. So we do some initial assessments and screening. Again, in our clinic, we are able to screen all patients once a year who come in, and we see about 4,000 patients a year right now. So we're able to do an initial assessment, look at their basic laboratory values, general trajectories and waist circumference, and see if those are stable. If for whatever reason they're not, or a patient says they have questions, one of our registered dietitians schedules an appointment time. At that point, we also have the ability to refer someone to a certified diabetes educator who has expertise in nutrition. And again, we fund that through the 340B drug pricing program so that we can address issues specific to their HIV medications. We have the situation where many patients are starting to be concerned about body composition changes related to HIV. So we're able to actually refer them to a dietitian as opposed to adjust their pharmaceutical therapy and ART regimens, as many providers were trying to do initially. And then we also have a situation where more patients are asking about GLP-1 agonists for diabetes care and body weight management. So we, again, will refer those individuals to our dietitians to help provide referrals and look at coupon programs for those. So that's a brief look at what we do in some of our clinic programs. And I will say, again, a lot of these assessments depend on having registered dietitians either in your program or with a community partner that you can work with. But thank you.
Great. Thank you, Dr. Willig. And I'm now going to go ahead and introduce Dr. Nancy Sheehan, who's going to be talking about polypharmacy and drug-drug interactions.
Thank you. Hello, everyone. And first, I'd like to thank the organizers for inviting me to be part of this panel session. So we're given the opportunity to prepare a few slides. So I just have a few, just to highlight a few points and to discuss the, how the pharmacists at our clinic manage drug-drug interactions. So the first slide is actually just to show an overview of a bit of the prevalence of polypharmacy, as well as, potentially inappropriate medications. And there were many, publications reports that have been published over the years, but I'm just presenting here the Swiss HIV cohort data, just because they've presented data in 2011 where they were looking at people with HIV above 50 years old or below. And most recently, they've reassessed their cohort looking at people 65 years and above. And what's interesting to highlight is, the older population have been diagnosed with HIV for a longer period. So 51% have been diagnosed before 2000, and 46% have started antiretrovirals before 2000 as well. Because of multi-resistant virus, there's still a high proportion of patients, despite the advent of integrase inhibitors that are very well tolerated and have few interactions, there's still a high proportion, up to 35% of patients today that do need to stay on ritonavir-boosted protease inhibitors. The definition of polypharmacy, this can be debated, but what's commonly used is 5 or more co-medications in addition to the antiretrovirals. And in the newest data from 2019, their prevalence was 43%. And I think this is, it's definitely high, but what's interesting is that many of, at least the patients that I see in our clinic, have a really high number of co-medications, up to 15, 20, 25. And so I think we're not seeing the amplitude or magnitude of polypharmacy by just looking at co-meds and above. Interestingly, in their cohort, they found that people below 65 years old and those 65 and above had similar prevalence of significant drug-drug interactions. And so this is surprising. I think most cohort data has shown the opposite, and they had shown this already in 2011, where people that are older because of comorbidities and more polypharmacy have more risk of significant drug interactions. And they, in the 2019 data, suggested this is because the HIV clinicians at their clinic in Switzerland are used to managing drug-drug interactions and preventing drug interactions. They focus mostly on cardiovascular and CNS drug-drug interactions, but we know that drug-drug interactions are possible with many other classes of medications, which perhaps are not reflected here in this data. And then the prevalence of potentially inappropriate medications using Beer's criteria was 31%. Next slide. So at our clinic, we run a consultation service, the pharmacy team. And just because we're unfortunately not, we have one full-time equivalent pharmacist at our clinic for about 2,000 patients. So we unfortunately can't see all patients, but the ideal would be to do an annual review of medications, including prescribed, over-the-counter, natural health products, recreational drugs, to identify the potentially inappropriate medications, the medication cascades, and potentially significant drug-drug interactions. And all of these should hopefully lead to deprescription. And this is definitely something that in geriatrics, people are aware of. But even for HIV, we should start thinking, can we deprescribe if, for example, dual therapy could be effective for that person's viruses? Obviously, we'd like to, remove ritonavir, remove cobicistat, remove tenofovir diazoproxil if ever possible. Our challenges at our clinic is that we're seeing patients with more non-AIDS defining cancers. So now we're having to deal with drug-drug interactions with chemotherapy, transplant medications, and in many situations, we can't remove the ritonavir or cobicistat because of multi-resistant virus, or because patients are actually stable on these regimens, and doing these switches would be extremely difficult. On the next slide, really quickly, have two fictional cases inspired by patients at our clinic. In the first, a patient with multi-resistant virus with a very complex drug antiretroviral regimen, but has been exposed since 1994 to antiretroviral therapy, has had 15 different antiretroviral regimens. Viruses have developed resistance, and though we would have liked to remove the ritonavir, we stuck with keeping it, but we were still able to decrease pill burden, which can improve pill fatigue. And in the second case, a 70-year-old woman with no significant resistance, so we could remove the cobicistat in this case, but this person already had many drug-drug interactions with cobicistat that were well controlled. So though ideally we want to remove cobicistat to prevent drug interactions in the future, if we do this, we have to have everyone that's on board, very motivated. This includes the patient, the physicians, the pharmacists, the nurses, to do the necessary follow-up that will be needed, close follow-up for many weeks to months to stabilize everything once we remove the cobicistat. So I'll stop there, and we can continue with questions later on. Thank you.
Great. Thank you so much, Dr. Sheehan. And I'm now going to turn it over to our next speaker, Dr. Luigi Ferrucci.
Hi. It's really a pleasure to be here. I don't really have slides today, and I feel like I'm a fish outside my pond because I don't take care of people with HIV. I no longer take care of all the people clinically because I have been a geriatrician for many, many years. But then I switched to the dark side of the moon and I became a gerontologist, mostly a researcher, working in the Baltimore Longitudinal Study of Aging. And I've been asked to talk about physical activity and exercise, which is one of the really most beloved topics that I want to work in aging. And so what I tell you is certainly valid for older people, but I am almost sure that for everybody that is a condition of low resiliency will certainly be important as well. So one of the things that we have discovered in geriatric medic is that health is better measured in terms of physical function. The number of disease or the severity of disease does not describe health because the effect of aging and the effect of lack of resiliency is associated with global susceptibility to disease. And so when I give presentation, people always ask me, so what can we do? What should I do not to age, faster and to maintain the blessing condition that I have now? And instead of waiting for the new miraculous drugs come in, I always tell them, they have a magic pill, and that magic pill is called exercise. From the point of view of the biology, we know, for example, the exercise affect all the resilience strategies that we call the hallmarks of aging, which really are the mechanisms that maintain the homeostatic capacity in our body. Improve mitochondrial function, improve mitophagy, has an effect on angiogenesis, has an effect on nutrient sensing, has an effect on DNA repair. But from the epidemiological perspective, the effect of exercise are enormous. We know that the people that exercise even a little bit, the difference between being totally sedentary and walking 10 minutes per day at normal speed is almost 3.5 year or longer survival. And of course, when you increase your physical activity, you get even more, but it's never as much as between sedentary state and having a little bit of physical activity. This is extremely important when we talk about older people and when we talk about sick patients, because the sick patient, they are told that they need to exercise more and they think that they need to go out and jog in the morning. And of course, they're frightened. They think that they cannot do it. But if you tell them, start really, really slow, start really by walking every morning, twice around your block. And, many of my patients, when I used to have patients, were really willing to do that. And then they find confidence and they find that the beneficial effect of exercise is immediately perceivable. We know, for example, that physical activity, even very moderate, is associated with lower risk of depression, is associated with reduced risk of having anxiety. And we do know that it's associated with lower risk of cardiovascular disease. That is one of the burden that everybody with an overt inflammatory disease such as HIV has. And in fact, if we talk about inflammation, there are large studies that have shown that while the acute effect of exercise increase some of these inflammatory markers, such as the IL-6, because we know that many of these are really myokines, as time goes by, for people that keep exercising, they can reduce the inflammatory state. Chronically, there is a very beneficial effect. So I think that, the message for me has always been, whatever is your condition, in whatever situation you are, increase your physical activity, even a little bit. And there is no better gift that you can give to yourself and to improve your health. We don't need to wait for the magic pill. We already have one.
Great. Thank you so much, Dr. Ferrucci, for that perspective. And I'm going to turn it over now to our final panelist, Mr. Jules Levin, who's going to share his perspective, the patient perspective, or older person living with HIV.
Thank you, Dr. Green. This conference was very good. It really touched on so many of the real problems that older and elderly people with HIV are facing, including cognitive impairment and the brain and frailty and the more social aspects like isolation and lack of social engagement. I have to say that everything that was discussed here, I suffer with. I'm 72. I've had HIV for about 40 years now. And I want to touch on a few things that really need to be discussed and addressed. Aside from all the excellent research and presentations here today, let me tell you, I work with a lot of people with HIV all over the United States, all different types that cut across all demographics. And as well, I work with people who are aging and elderly in Europe as well. And let me tell you, in no uncertain terms, that people here in the United States with HIV who are aging and elderly, as well as people in Europe, they know very little about aging. They don't understand the issues for the most part. They don't understand what aging really is. They don't understand what frailty is. They don't understand what cognitive impairment is. They have very little knowledge about things like osteoporosis and fractures and falls and their risks. So I know that all of you understand all this, but they know nothing about any of this. And I think the fault lies with the lack of education from state and federal governments and local governments, and from misleading information from federal authorities. For example, telling everybody that lifespan is almost the same for us as for everybody without HIV, when we know that's just not true. The data shows about a 9-year difference. We have no screening, essentially, and care and services for elderly and aging people in the clinics, aside from what you guys do that presented here, like Dr. Kondo's clinic in New York and Dr. Green's clinic in San Francisco. This is just a small handful of clinics that, you know, serve maybe a couple of thousand people when there are over 200,000 people over 60 in the United States right now. It remains to be seen if the program in New York State will actually fix care. I frankly have my doubts. The HRSA RFP is only $10 million for 3 years for 10 clinics. So we're talking about 2,000 people. In the meantime, the remaining 200,000 people are getting nothing in the clinic. There are no exercise and diet programs in the clinic. So policy is absent. It's invisible, essentially. And federal and state officials are not addressing this. And let me just say that very soon, in my opinion, death rates will start increasing for elderly people with HIV. And as mentioned here several times, we are facing a silver tsunami, and we are not prepared for this. Thank you.
Thank you so much, Jules, for sharing that important perspective. And we're now going to open up to discussion for all of the panelists who are going to join us. And I believe Dr. Ansys has to leave a little early, so I did want to direct two questions that came in specifically for him first. One was from Sue Newman. Are there any new approaches or medications for chronic neuropathy, especially medications do not interfere with concentration or focus?
No, that's a great question. So when I have patients who have peripheral neuropathy, I'm kind of approaching them on a multi-tiered kind of plan for them. So some of the things that we really consider for them is certain short-term kinds of relief. So I do talk to them about capsaicin or other kinds of creams. Some people find significant relief from that. I also work with them, and you already heard it from Dr. Ferrucci about, I talk to them about other ways that they could improve blood flow, improve other kinds of ways to the muscles and to the nerves. And so I say gentle exercising. And as you heard, even walking around the block, doing a couple things, I say to them, I'm not expecting you to run a marathon, a half marathon, or even a 5K. Simple things of just getting outside and doing that and interacting can also be very, very important. You also heard from Jules as well about that isolation. So getting out and being interactive is also very important. I then also go through other complementary methods that can be thought about, and that can be even yoga, and it can even be chair yoga, and can be simple kinds of methods like that, or other kinds of stretches that can be done for them. I also think about mindfulness or other breathing exercises to see if they can find and concentrate on some of that. I work through them, and we have a pharmacist here, and we've already heard, and a complementary and geriatrician. I look at the medications, because sometimes the medications that they may have been exposed to in the past may have led to some of these kinds of changes. And you've already heard of some of the other newer medications that we can consider. But it's hard to regrow those nerves. And so if they're having positive symptoms, meaning that they're still having that tingling, those pains and that kind of stuff, we think of certain kinds of medications. And most of them are medications that you probably already heard of. So something called gabapentin or Neurontin, pregabalin, duloxetine. I'm looking at those kinds of medications and trying to think about, or amitriptyline. I'm trying to think of those kinds of medications for them. I do not, and I can say within my one hand of how many patients I kind of prescribe narcotics. I really try to stay away from that, because that can affect the concentration. That can affect some of their thinking issues. And so I really try to stay away from that. And then I also kind of work with them, and we also have a pharmacist on board, is that I kind of work, what are the main medications that they need, and working with them even with a simple thing like a pill box, and kind of having so that they can remember and remind them. And so they don't have to, did I take this medication or not? I know it's always set out on whatever day. And I now know that every day of the week I'm taking those kinds of medications. So it's kind of a multi-pronged approach for the neuropathy. There was a second question on the question of nimodipine and calcium channel blockers. I don't really prescribe calcium channel blockers for individuals for cognitive. I'm not seeing that much of seen studies that have led to changes in cognition with that kind of medication. I do want to bring up a topic, and this was discussed by Dr. Maslia and others, and I know Jules has brought this up as well too, is the real big elephant in the room with our older adults who are HIV positive, and that is Alzheimer's disease. I'm going to be telling you, we now have blood tests. It is absolutely remarkable. They will be coming out. They look very, 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 I hope I put enough berries in there, promising measures to look at individuals. And I think that is going to be the wave of the future. And imaging techniques are going to still be important, but they're going to be less, or even the lumbar puncture spinal taps are going to be less. It's really going to be these now new blood tests. The issue is that we actually have a medication, if some of you have seen in the news, that looks very, very promising. And there was a medication that was previously approved for Alzheimer's disease, but there's been a big controversy. The biggest question, though, is if you actually look in those studies, and a kind of exclusion for those studies has been that if you're HIV positive. And so we really need to look at these kinds of markers and look at these potential therapies in these individuals. And so it's an open field. And really needs to be really more discussed. And I know Jules and others are really pushing that forward. And then we have a number of other people, Dr. Latender, Dr. Ellis, Dr. Moore, and others, and Dr. Rubin. I can name a lot of people who are doing that.
Great, thank you. And I wanted to give Dr. Sheehan, our pharmacist, as Dr. Ansis was talking about, if you wanted to add anything about the comment of neuropathy and medications to treat it.
No, I mean, I think our approach is the same, Dr. Ansis, and the types of medications that we'd recommend. Obviously, choosing some as much as possible that don't need dose adjustments for people with renal impairment, and tailoring the dose or titrating the dose very slowly because we know that they might be more exposed to more CNS side effects. So I think, start low, go slow is still the best approach for any, I would say, any medication in the aging population.
Great, thank you. There's geriatric pearls in all of these comments. And one thing I just wanted to echo was in many of the talks, there was mention of team. Dr. Ansis just gave that even in his approach to neuropathy, and Dr. Kondo and Dr. Willig, everyone has talked about the team that they work with. And so I'm wondering if someone or anyone on the panel can comment on their thoughts of working with a multidisciplinary teams. And the question I'm often asked is, well, if you're a solo practitioner or you're not in a setting where that feels conducive, how might you approach this? And maybe I'd add on, like, what are the maybe policy or structural things we need in place to really help support these kind of multidisciplinary care models? Oh, Dr. Kondo, it looks like you're muted.
I can comment. I really love working in an interdisciplinary team. Trained as a geriatrician, that's sort of just like what you do, and it's really the best care for patients. I think we each bring an expertise to the patient's care, and we all have different personalities and connect differently with patients. And so I find even that patients will tell certain members of my team something that they don't feel comfortable telling me about, but maybe is important to their care that we need to then discuss as an interdisciplinary team to come up with a plan for the patient. So I think team-based care is really important for older adults. It's also, I don't have the time to do everything for each patient that I see. So having a team to be able to do some of these assessments that are important, like reviewing medications, going through drug interactions, making sure all of the medications are appropriately dosed for renal function and liver function, having somebody else be able to do that for you is really helpful and important. And I can't tell you how many times we found medication errors or drug interactions that we've recommended changing to really help improve patient care. So I think we pick up a lot more potential errors in working as a team. I think in places where you don't have the luxury of having a team, I like to just think of breaking things down. So as a geriatrician, and I'm thinking about seeing a patient and really thinking about 5 M's of geriatrics, if you have the time, maybe address 1 M or one piece of an M, right? So if you're thinking, I'm seeing a patient today for follow-up, maybe I can address minds, let me assess for depression, let me do a PHQ-2, and just starting one small step at a time to do at least some of the assessments if you're by yourself and you don't have a team to help you with all of them.
Great. Does anyone else want to add to Dr. Kondo's comments?
I can just add to her comment and specifically also addressing something else that someone raised about how do we train the next generation of HIV and geriatrics providers. I would say even if you are a member of a solo practice and coming into a clinic setting, it is very important to find a way to get involved with the existing team structure. From a dietitian perspective, right as I was coming into practice in the HIV setting, the dietitians and HIV group for the Academy of Nutrition and Dietetics actually was disbanded because the numbers were so small. Why were the numbers so small? Again, because of lack of consistent reimbursement, small amounts of reimbursement within the setting of Ryan White funding that was available. And in many cases, people were subcontracting for a dietitian to come in and do screening, quick checklist, but not really providing funds for the time for them to actually do full assessments and interventions with the patient. So I think structurally, we have to look at the existing funding revenues that are in place to actually bring people in and provide, whether it's office space or additional meeting times that are available as part of the clinical care team, to get these practitioners actually involved so that they can see that there's value in participating in an interdisciplinary network, even if at times you're the only person within your specific subspecialty, that you bring a value to the team at large. And I think the other part of that is going to be bringing as many interns, fellows, trainees in the different disciplines as you can into the clinic settings. I know that has been very challenging in the midst of the pandemic over the past couple of years, but the more that we can get them exposed to the actual clinical care and at the same time advocating for that financial reimbursement model, I think we're going to have more luck in actually getting people into practice and appreciating the value of interdisciplinary work.
Great, thanks. And maybe there were also a lot of questions coming in around how can we enable diet and activity. There was a question about accurately assessing metabolic rate in the clinic that enables evidence-based changes in diet or activity besides just saying eat less, exercise more. Other questions around resources supporting that. I don't know, Dr. Willig, if you want to take that question and then.
Sure. All right. So as far as measuring resting metabolic rate or metabolic rate well in a clinic setting, that is very challenging to do. Just because to actually meaningfully measure this, you have to have certain conditions set up. And to tell a clinic that you're going to reserve an exam room that's going to keep a specific ambient temperature that people will only be coming in and out of for specifically this one test is highly unlikely. That space is very valued for the aspects of patient care. There's also the fact that I can tell you that 1 cup of cooked carrots has 80 calories, but due to inflammation, mitochondrial damage, your unique physiology, that may actually translate to 75 calories absorbed for me, 82 calories absorbed for Dr. Ferrucci, and on and on. So there's a lot of unique physiological aspects. But the second someone tells a patient to eat less and move more, I would say very kindly and politely, end your relationship with this individual and find someone else in the clinic who's willing to spend the time to tailor advice. What you really want to do is talk to that person about what are the foods and food preparation techniques that are culturally acceptable to you. What are you used to in the house? How can we shift your diet in a way that's meaningful to you? That's the first stage at which you really go into that initial deep dive of just basic food patterns. Because the one thing we found over and over again is that we so often assume that certain people will have a basic knowledge base. And very often that is not the case. And this can be someone who has not had much education all the way to someone who has had extended higher education over the years. Their knowledge base in this one area oftentimes can be lacking. So those basic nutrition principles still matter in the context of how that person is provided care. Two big areas where that really comes out to play are for someone with HIV, their needs for dietary protein and dietary fiber, right? So we see this chronic inflammation in someone who's living with HIV, and we know that two very important ways to actually improve this are going to be to make sure they have adequate dietary protein and adequate fiber. While the standard recommendations for dietary fiber seem to be appropriate for an older person, so that around 21 grams for women up to around 30 grams for men, to help combat inflammation, standard guidelines for dietary protein are inadequate. We want to see patients eating at least 1.2 grams per kilogram of their body weight per day of dietary protein. So just telling someone that information and sending them on their way is not really going to get it done. Literally giving them portion sheet sizes, using their hand to show them on their hand or some tool of their body, this is what a serving looks like for you. This is how much of these various food sources you need to eat to get enough of this dietary protein. Are you vegetarian or not? And if so, we adjust this. You know, we want to see you eating 1.2 grams a day, maybe anywhere up to 1.4 or 1.6 if you're actively training or getting older, to really combat that inflammation. So there are so many areas in which it's really specific to someone with HIV that we have to tailor the nutrition, first of all, because of the HIV, and second of all, because of their lifestyle. And while we don't have good ways to measure metabolic rate yet itself, oftentimes, even just starting with those basic principles are enough to get them to a stable place with their health. I will just briefly mention too that the other thing that we have to ask about are nutritional supplements. We are very fortunate that we're at a point in time when very few nutritional supplements will actually interfere with someone's HIV therapy. That list has become smaller and smaller as HIV therapy has continued to improve. But we are seeing a lot of herbal and vitamin and mineral supplements that are starting to interfere with other aspects of diabetes-related care, cardiovascular disease, and other health. You know, during the pandemic, we were seeing toxicities resulting from excess vitamin D and zinc consumption, which I never thought I would see. We still have people obtaining clay from different gas stations, engaging in pike and that type of thing. Yellow jacket supplements are very common, at least in the United States, because of the energy and ephedra compounds, and that interacts with multiple medications. So trying to ask about those things and, again, communicate with the team what's going on are going to be key.
Great. Thank you. And there's a lot coming in the chat, and I want to try to get to all of these things. I do want to come back because there's some comments to you around increasing from Dr. Erlandson, you know, the small pipeline of trainees that choose to focus on HIV or geriatrics, and how can we also encourage more trainees to focus in this area? And I actually want to ask Dr. Sheehan, because I remember in your bio, you said specifically, I think pharmacy residents have to go through an HIV geriatric rotation. Others can comment on that. And I would also add on for Jules, what would you think is helpful to educate older people living with HIV about the concerns? Because you mentioned many are not aware. So maybe Dr. Sheehan and then Jules.
Right, so thank you for the question and for highlighting this. We have a year 2 HIV pharmacy residency program at our center, which is a joint program with Toronto General Hospital. So these, just for people who don't know the pharmacy sort of context in Canada or in North America, most pharmacists who want to go on to work in hospitals do 1-year residency program, and then they can do year 2 programs, which are specialty pharmacy residency. So this is what we offer. We offer an HIV pharmacy residency, and as part of that, they have a mandatory HIV geriatrics rotation, and we work closely with Dr. Falutz from our clinic, who's geriatrician, to do these comprehensive medication assessments in people that are 65 years or older. And so we used to have a mandatory pediatric HIV rotation in our residency program, and we've changed that because of changing epidemiology to this mandatory HIV geriatrics rotation.
Great. And Jules?
So the biggest problem in care for older people in the United States is the 20-minute visit. This is absurd. It is just atrocious, And it's the main reason why people with HIV get horrible care when they're older and aging, because they need more time, not less. If you're 25 or 30 and you go in and all you really need is your viral load check, 20 minutes may be more than necessary. But if you're 65 with 10 comorbidities, 20 minutes is going to kill you rather than help you. And it's the same thing when you get referred to a specialist. It's the same 20 minutes. And all too often in New York, your HIV primary care doc is not really communicating with the specialist about what happened. They may read the notes in the portal, but that's about it. So it's really a horrible care system. So the question that came in the chat was, what will contribute to increasing mortality? Well, this is what I tell all the patients that I work with. Be aware of your labs, know your labs, understand your labs, engage with your doctors. What do these lipids mean? What do these labs mean? What is my kidney function? What is my heart disease? What is my osteoporosis situation? And make sure that the doctor spends time educating you, because doctors are not educating patients about this either, because they only have 20 minutes. Now, I know in New York City that nobody is doing bone mineral density testing. Somebody said that at 50 in Canada, they're supposed to do it. Well, they're supposed to do it here in the United States too, for people with HIV at 50, and nobody's doing it. I know people who are 70 years old at Mount Sinai in New York who have had multiple falls, and they've never had a bone mineral density test. It's just beyond the pale. So having said that, I also want to say that I think we should bring back home care. Doctors should start visiting elderly patients in their home. Peter Hunt in San Francisco does that. The question came up about, and so we need to revisit home-based care, whether it's by nurses or doctors. And Dr. Hunt told me he actually goes to visit patients in their home. And somebody raised the issue of nursing homes. Well, the data shows that the number of people who are being put in nursing homes, elderly with HIV, has doubled in recent years. We're not discussing this at all. We're not addressing this at all. And so, in order to, in the chat, it was raised about increasing mortality, or rather increasing lifespan, is just increasing health span is just as important as lifespan. And I totally agree. Quality of life is horrible. So all these things I mentioned may help quality of life. We need programs in the clinic for exercise and for diet for patients. We need programs for social engagement. All sorts of programs could be implemented. And lastly, what I want to say is that the federal and state governments, what they're doing, as you all know, is putting all their money into PrEP and cure, and it's all politics. And they are ignoring the needs of the aging and elderly population. And that is the crux of the matter. The politics are killing us.
Thank you, Jules, for that perspective. And I just wanted to see if any of the other panelists wanted to expand on any of those points. There are some other questions coming in the chat, or any other thoughts on long-term care for people with HIV.
I'd just like to comment on a few things that Jules said. Jules, I think you're 100% right. You know, the HIV primary care providers don't get enough time with their patients, and I feel very fortunate that I get to spend an hour with a new patient. And sometimes I feel overwhelmed, and I don't think that's enough time. And how do we really overcome that? You know, I try to schedule frequent follow-ups, and that is also challenging in our geriatric population, because if mobility is a big issue, getting them back out to the clinic a second time can be a barrier, right? And so can we leverage telehealth in that case, whether it's video visit or a phone visit for follow-up, to address things that we couldn't, you know, fit in at our initial visit? I think the question of home visits is a wonderful idea. I'm a huge proponent of home visits and getting a sense of how patients are really functioning in their home setting. And, you know, many of the patients that I see, one of their big goals is staying functional, independent in their homes. And as we onboard our community health worker, part of her role, we're hoping, is going to be doing some home assessments and going into the home of older adults with HIV. So, you know, I think you're 100% right on these problems that we have in our healthcare system right now, but I hope that there's a little bit of hope that we are trying to work and improve on some of these things.
Great, thanks, Dr. Kondo. There's another question related to that coming in about, given the time that it takes to do comprehensive assessment of all of these concerns, is there a differentiated HIV service delivery model for this aging population of people living with HIV, especially in resource limited settings? Just acknowledging too, we have a panel of North America, but I'm curious if anyone has thoughts about how some of these things might also be adapted to other settings, not just in the United States and Canada. And thank you, Dr. Ferrucci and Dr. Ansys, who had to leave. Go ahead, Dr. Willig.
I was going to say, I know one of the things that's become very clear from some of the work that's been done by our colleagues in Zambia and in South Africa is the discrepancy in diet quality as income increases, right? So we know that there are certain issues that are prevalent with food insecurity. In some settings, as someone has more income, you see their diet quality decrease. In locations such as the United States and Canada, typically you'll see diet quality improve. As income improves due to the cost of various foods and the cost of processed foods in different global settings, right? So I think for us, a lot of times, our colleagues in Zambia that work with the Adolescent Girls Empowerment Program, specifically those who are diagnosed living with HIV, were able to transfer a lot of that work to their aging community. They do not have aging clinics specifically because they simply don't have the bandwidth and resource. But they found that some of the questions were translating still across generations, from the setting of how do you take, again, the sort of culturally tailored and appropriate foods and find ways to stretch resources, if you will. So they developed an entire curriculum around affordable foods that were culturally acceptable, how to prepare them, but most importantly, how to store them, so how to minimize the waste. And then based on that work, we were actually able to come back and do the same thing at our clinic in Birmingham. Again, we're lucky to partner with our community partner operating our food assistance program, but they have entire curricula designed around affordability, both at the local level and national, how to deal with inflation and rising food prices, how to keep food fresh for as long as possible, how to store things appropriately. And what we found over time is that there's been actually much more communication between Birmingham and Zambia because of issues keep coming up, whether it's inflation, seasonal price shifts, drought or famine in different regions, the same questions keep coming up over and over again. So I think it's constantly sort of asking your population not only what's meaningful to them, but also you have to follow governmental issues a little bit. So you have to be aware of what's happening with food prices in the grocery store, but you also have to be aware enough of the political setting to know what's coming 6 months down the road with food prices, what's happening as far as global conflicts or global weather patterns that might impact the price of eggs or might impact the availability of wheat 9 months down the road for your patients, and sort of be a little bit prepared with curricula to deal with that, which is not easy, but necessary.
Yeah, so I want to thank all our panelists. Maybe I would just summarize, I think, meeting where the person is and thinking what matters most, and some of the policy and structural issues that really do impact globally everyone, that we have to think about on a day-to-day basis in our clinical practices. I want to we could talk for hours. I feel this session could honestly go for much longer. But I want to go ahead and just thank all of our panelists for participating today and the great comments that are still coming in. And I'm going to now invite Dr. Moore to close out the conference.
Wonderful. Thank you for such an amazing final panel. It was really engaging, and I agree with you, Meredith. We could have that go on for hours, and I hope that the discussions will continue after the formal close of this workshop. So I want to thank you all for attending the 13th International Workshop on HIV and Aging. I believe we've had a productive, engaging conference. We've had excellent presentations on biologic aging, neurocognitive functioning, inflammation, kidney functioning, and more. We had some excellent abstract presentations, the lightning poster session presentations, and the guided poster tours. These highlighted both national and international work. And I like that we hit on some important factors like social isolation, as well as ways to combat those through resilience methods, exercise, nutrition. And I really do want to encourage attendees to reach out to one another such that the conversations can continue on with other attendees and presenters. Certainly we learn a tremendous amount from collaborating with one another. And that's what's really essential for us to improve the lives of the people who are living with HIV. So if you could be so kind, it's really essential to us that we get the survey, the post-meeting survey. This helps us improve the conference for subsequent years. So please take the time to do that. It will really it'll really help us make sure that we can maximize the goals of this conference. Next. Here's our virtual photo. For those of you who have not attended this workshop in person, they always take a group photo. This is the hodgepodge of, that we've put together for the virtual group photo this year. And one thing that we really try and do at this workshop is to highlight the work of early career investigators. You'll notice that we had several presentations. I kept erroneously calling people doctor when they had not yet completed their doctorate and were early in their training. And we had 2 abstract presentations that were selected before we knew the training level of the abstracts that were submitted. And one of those is the winner of this year's Early Career Investigator Award. And that winner is Kaylin Peterson. Congratulations, Kaylin. I don't know if you want to say anything. Thanks for your participation.
Thank you very much, Dr. Moore. That is a huge honor given the context of the incredible presentations that we've had these last 2 days.
Thanks, Kaylin. Excellent presentation, excellent work. Keep it up. So I want to thank the organizing as well as the scientific committees that participated here. We had many abstracts, wonderful abstracts this year, and I think we had some of the highest rated abstracts on average that we've ever had. And thanks to my co-chairs, Christine Erlandson and Joe Margolick. Also, thanks to our sponsors, ViiV Healthcare, our platinum sponsor, our silver sponsors, MSD and Janssen, as well as our endorsers, people who really get the word out about our conference and make sure that as many people are aware of this conference's workshop as possible. And we just want to announce that we've identified the dates for the workshop next year. That'll be October 26th and 27th, 2023. We are fully intending to have a hybrid meeting, meaning there will be an in-person meeting that also allows for virtual attendance. So the location of that is being worked on, but please put this in your calendar. We'd love to have continued participation. And I think we all look forward to getting back, those of us who can, getting back in person to get some of those informal conversations that lead to fruitful collaborations. And with that, that's the close of the workshop. Thank you for attending and thank you for participating. We really appreciate it. Have a wonderful rest of your day.
Thank you.